Okay, I think everybody's in. Hello, everybody, and welcome to Carolina Simulation Center's Brown Bag Series. We do really appreciate you joining us today. My name is Darla Morton, and I am the Senior Research Associate here at Carolina Simulation Center, Atrium Health, and Wake Forest School of Medicine. This series is meant to provide an opportunity for those in the healthcare simulation community to learn about topics related to simulation, to highlight previous research and opportunities for the future, and engage in discussion about ways to continue moving simulation-based education and healthcare forward together. Today, we are very excited to have with us Dr. Kim Layton, who is a PhD registered nurse. She is a certified simulation educator and operations specialist. She is a fellow of the Academy of Nursing Education, the Society for Simulation in Healthcare, and the American Academy of Nursing. And she is the executive director of the ITCON Clinical Simulation and Innovation Center located in Doha, Qatar. Kim will be presenting on the topic of evaluating clinical education. And before I turn it over to her, I wanted to go over just a few housekeeping items. Today's session will be audio video recorded and shared with interested parties in our private YouTube account. We will send today's attendees the private link to the video, or you can visit our Carolina Simulation Center's website, the research section of that, where the link will be uploaded in the next couple weeks, and that is carolinasimulationcenter.org. During the presentation, we ask that everyone stay on mute and utilize the chat to ask questions and share your thoughts if needed. Please feel free to eat your lunch, and since there are possible issues with Wi-Fi both here and on the presenter's end, please keep cameras off during the presentation. After the presentation, you can turn your cameras on, and then we'll do our question and answer time, and you can unmute to ask questions then. We will be monitoring the chat to ensure everyone's comments and questions are shared. If there are any questions before we begin, please ask them in the chat now. Those could include technical issues or whatever. We'll have people monitoring for that. While we are waiting on questions, I would like to introduce the newest member of our Carolina Simulation team and research manager, Dr. Megan Stuhlman. Megan, would you hop on and say hi for a quick minute?
Thank you so much, Darla. Yeah, I'm so glad to be part of the Carolina Simulation Center team, and I'm excited to continue working with the team here to, push forward the research and assessment initiatives that are so crucial to our understanding of what educational practices support our learners best. And I join Darla in thanking you for being here and talking with us today about your findings, Dr. Layton. Excited to hear from you.
Thanks, Megan, and I'm really glad that you're here with me. So, all right, I think there are no questions that I see in the chat. So I'm going to turn it over to Dr. Layton.
All righty, let me just share my screen here. Make sure I have the right one. Okay, can you tell me what you see, Darla? You see
I see your presentation. You're
okay.
Good to go.
I went all the way through a webinar one time only to find out at the end, they're like, can you do it again so that we can see your slides when we record it? And I'm like, oh gosh, I wish you had stopped me at the very beginning. But first of all, thank you so much for the invitation to spend some time with you here today, talking about nursing student competence, exploring some methods of evaluation. Well, we're working really hard to get these students ready for practice. And it was really great to meet so many of you at the IMSH conference a couple of weeks ago in Orlando. And I don't know about you guys, but I was surprised at how many people I had only met online before. And then once I got to IMSH, the opportunity to meet them in person was really fun. So I have no disclosures that have any bearing at all on this presentation. Just a little bit about my nursing background. So I have been a nurse for over 40 years, and 20 years of it was in the emergency department. And I left the ED over 20 years ago for the same reasons that the nurses in New York State went on strike a couple of weeks ago. So, you know, frustrating to see that the more things change, the more they say the same. But at that point, I moved to nursing education and then really quickly got involved in simulation. So our college president came to my office one day and asked if I wanted to go to Florida. And I lived in Nebraska and it was February. So of course I said yes. And she wanted me to check out this simulator and tell her whether to buy it. And she was so visionary and she already had the money. Now, for those of you who have been around a while, you might remember when the only simulator on the market cost $250,000, was the very first one. So her commitment was really big. And I went, I saw it, I called her and I said, write the check. So then when I got back home, she put me in charge of it because I was the expert. So there was a really low bar for expertise back then. But I thank her every day for the opportunity because it completely changed my career trajectory as well as my life. So our learning objectives for today, you know, I've kind of fallen into this niche of evaluation and creating evaluation instruments, but now we've really been working with colleagues to start chipping away at nursing education itself, especially the clinical education, and how we evaluate outcomes. So this leads me to the learning objectives for today, which are to discuss the systematic reviews of outcomes related to traditional clinical education, and to identify challenges to current methods of how we evaluate undergrad nursing students, and then to talk about appraising clinical evaluation tools and methods of evaluation. So here's some research findings that I find really distressing. So Dorothy Del Bueno, she's been studying readiness to practice for over 15 years using a tool called Performance-Based Development System, or PBDS. And some of you may be familiar with that. It's used in hospital systems. But in 2005, when she started, sorry, I have a typo on here. It should be 2005 instead of 2015. She reported that 35% of newly graduated RNs were in the safe or acceptable range for starting practice. But what that really meant was that 65% were not ready for practice. So it was about that time that the residency and internship programs started for the nursing graduates. But you can see in the ongoing work, the percentage of nurses ready for practice has just steadily declined. And the results from pre-COVID, only 9%. So if you think of nursing education as a business, only 9% of our product is ready for market, which is abysmal. You know, we assess using a variety of methods all through school, in skills, simulation, clinical, and the classroom, you know, trying to decide, are these students ready? Have they successfully completed our programs? Are they ready for practice? And yes, we say they're ready and we give them a diploma, they pass the NCLEX, and then they start their first nursing position and they're found not to be practice ready. So this is not a new gap between practice and education, but it's got serious consequences. So it really does need to be addressed. Now today, when I'm going to talk about evaluating clinical education, I want to include the traditional clinical environments like hospital, skilled nursing facility, clinics, and things like that, as well as the simulation lab, which is usually in either a hospital or an academic location, and uses a lot of different simulation modalities like mannequins, standardized patients. And I want to include skills labs too, because skills labs are full of task training, and it's also a form of simulation. So I'm going to talk about these three together. So most states allows some percentage of clinical to be replaced with simulation. So if that's the case, then we should evaluate students in the same way in both environments, right? Should we evaluate them using the same tools? I want to know what you think about that statement and that question. Can you just write your thoughts in the chat box? I'll give you a couple of minutes. If it's all the same, should we evaluate it all the same way? Okay, Crystal's saying that maybe if we use NCLEX as our common evaluation, which would help us to evaluate the knowledge part of it, but perhaps not the performance part. And Amy's suggesting that it would be different because clinical is not standardized like it is in simulation settings. Any other thoughts? Yeah, I just wonder, I mean, logically in my brain, I think yes, but then the reality is that the learning environments are really too different, like Amy alludes to here. And, you know, you've got, are you teaching in simulation as a formative level, you know, learning from mistakes? But when you're caring for real people, then does it become high stakes? Because those errors matter. Megan says performance in clinical is different than sim because the simulation environment is controlled, whereas the clinical settings are not. So very true. In some respects, that makes it easier to evaluate in simulation than it does in traditional clinical. And I'm going to talk a little bit more about that. All right. Okay. Thank you for those answers. So now I'd like to ask you, again in the chat box, can you tell me what evaluation tools you use for simulation? Maybe the names of them, if you know if they have established reliability and validity when you're using them. I'm curious what you use. Ashley uses a rubric based on CUSIM competencies. Lassiter clinical judgment rubric. Ashley, I'm curious, did you guys develop the rubric? Did you or the faculty or the educators develop the rubric, or is it something CUSIM has released? Or maybe just not sure. All right, so we've got a couple of rubrics. I'm not sure how it was originally developed, but you updated it to be more appropriate. Okay, good. So it sounds like you've taken some time to look at the validity of that tool and make sure it works for your group of people then. So that's great to hear. So my next question is, what are the names of the evaluation tools that you use for your hospital-based clinical, your traditional clinical environments? And do they have validity and reliability? All right, that is kind of the okay. Use a self-developed evaluation tool that aligns with your SLOs, not evaluated for reliability and validity. Okay, thank you, Amy. Okay, the CLE, what is that? Clinical, I'm guessing, Bobby, it's what, clinical learning evaluation, and then OSIN competencies, clinical learning evaluation tool. Okay, great. All right, good. Thanks you guys for sharing that. I appreciate it. This is really where the disconnect starts to happen with evaluating clinical. So, we have focused a great deal in simulation on using tools that have been validated for use with nursing or healthcare professional students and that produce reliable data. So, essentially meaning it's the right tool for the learner group and it works the same way every time it's used. But I also know that sometimes the wrong tool is chosen for the wrong purposes. And I know that because of the requests I get to use my tools for research. One of the most common is people will ask to use the SET-M or the Simulation Effectiveness Tool Modified, and they'll ask if they can use it to measure competency or knowledge, which is not what it measures. The SET-M measures how well the learners think their learning needs were met in simulation. And so the SET-M really evaluates us. It evaluates the people who design the experience and not the learners at all. So a lot of times it happens that the right tools are not used for the right reason, or a tool was developed for medical students and then people want to use it for nursing students. And sometimes that works fine. Sometimes it doesn't. So there has to be a little validity and reliability work done along with it. So let's talk a little bit about the clinical learning experience, like a traditional hospital-based experience. And I'm going to share this story from the depths of my memories, or also known as the stuff of my nightmares. I'm not sure which, and how I recall being a clinical instructor. So my clinical site was the orthotrauma unit, and I had nursing students that were attending their first clinical experience. And there's a whole lot wrong with that statement for starters, because orthotrauma should probably not be the starting point for a brand new student. But you have to manage what you have, right? So while a fractured hip might be a good patient for a novice, she isn't if she's laid on the floor for 5 days and has rhabdomyolysis and requires dialysis. The man with bilateral calcaneus or heel fractures, well, physically, he's not a difficult patient to take care of, but he got the fractures when he jumped out of a 3rd-story window in a suicide attempt. And mental health wasn't taught until 3 semesters later. Okay, so I have 8 students on this unit. None of them are getting an appropriately leveled experience, really. Now let's talk about treatments, right? Everybody has a Foley, everybody has an IV or 2. Some have PCAs, and most needed a sterile dressing change. And, don't forget, they have to be up in the chair for breakfast. Then there's medication time. Now, I think it has to be a prerequisite to admission that a patient takes at least 5 to 7 medications. And then you add in the oral pain med, the IV pain med, the anti-nausea, the anti-diarrhea, the anti-constipation, and the anti-every side effect of all the medications. And then don't forget about the new anticoagulants. And of course, they all have to be given at 9 a.m. So who decided this anyway? The order says once a day. So why is the nurse or the student late if they give the once a day at 10:01? I mean, not only then do you have to ensure the students all give the correct medications to the right person, but before they give the med, We have them spew back this litany of every little known fact about each of the drugs. They spend hours memorizing the information the night before. They make flashcards. And all the time they're terrified that they're not going to know the answer to the one obscure question that we're going to ask them. Meanwhile, there's an app for looking up meds. So you have to start to wonder, who made these rules? And why are we teaching the same way that I was taught 40 plus years ago? It's just not making sense to me anymore. You know, of course, the nursing student needs to know why they're giving the meds, but everything else for every single drug for every patient? Because let's be real, as the clinical instructor, do you know all those details about every medication that your student's giving? I mean, I didn't. So what part of their brain does the critical thinking and clinical judgment fit into when it's full of all this memorized information and anxiety? Now, remember, these 8 students are all mine. And honestly, I was pretty lucky. Our ratios were low because other schools aren't that fortunate. But let's think about this a minute. If I'm supposed to watch every orthopedic dressing change and ensure sterile technique, and that they followed the 28 steps on the dressing change checklist, in order, mind you, and I have to observe their physical assessment skills, I have to watch them transfer and move people around so that I can make sure nobody gets hurt, I have to watch them do central line care and maintain sterility there, and of course, make sure that approximately 80 medications were correctly delivered at exactly 9 o'clock to 10 o'clock, and that the patients are bathed and they're ambulated and they get to their tests on time and they're back up for lunch. And now it's medication time again. Now, how am I supposed to evaluate them? Other than their ability to do their skills, which has already been evaluated in the skills lab. Now it's time for post-conference. Everybody's exhausted, especially me, but the nurses need help on the floor because 2 post-ops are coming back at the same time and there's a new admission. I honestly usually just kept the students on the floor, mostly because it gave them a chance to do more nursing things, but I also didn't understand the value of post-conference, which I would now do as a debriefing. And then on the drive home, all I thought about was the multi-page evaluations for these 8 students and how I was going to get through all their concept maps. And you know, there's always 1 or 2, and on a bad day, maybe 3 students that you had plenty to write about because nothing went right for them that day. And you spent most of your time with them. And the others, well, they must be okay. I mean, they told you they were when you asked them. And the nurses didn't complain about them. So a good evaluation for all of them. But did they really have a good day? Because we've learned in simulation that the ones that we thought were top performers in clinical really were not. And think about the ones we spend the most time with. It doesn't necessarily mean that they should receive low clinical grades for that week just because they were unfamiliar with a diagnosis or a medication or a treatment. I mean, it's their first clinical experience. They're at clinical to learn. So should they have to know everything and do everything correctly in order to be successful? So now let's fast forward to the next semester when this group gets sent off to a new clinical instructor. Now, will that clinical instructor have the same perspectives that I do? Probably not. Will they be different? Will they be the one everybody complains is unfair? Or will they be like the one everybody loves because she has them to her house for a pool party at the end of the semester? I wonder how this instructor is going to interpret the evaluation form. Is it this? I mean, it's the same form all through clinical, so she should all be doing it the same way, right? Well, we know that doesn't happen. Now think about skills lab. I don't know about where you live, but where I came from, At the beginning of every semester, we all sat around a table and we promised that we would all teach the skills in exactly the same way and evaluate the exact same way. By the list, no hints, no helping. Then at the end of the semester, the students complain because, well, he showed us a different way. She gave us hints and he didn't. It's so unfair. Well, you know what? They're right. It is unfair. And think about this. Skills checklists are done with a standardized checklist that the learner practices against multiple times. It has specific steps to do in order. There's nothing to do with critical thinking, clinical judgment, and all those other things that are on the other clinical evaluation tool. Now, we can't even get on the same page with a simple checklist. But we make high stakes decisions in many schools. In a lot of places, if a student doesn't get that skill right in 3 tries, and that happens with 2 different skills, they fail the course. They're exited from the program and they have to reapply, which not only is that a massive financial cost for the student, but it also delays entry to practice during a nursing shortage. And the reason for their failure might be us, because we're not consistent in our teaching and our evaluation processes. So what I'm really leading up to here is inter-rater reliability. When learners are judged based on observation of a skill or a behavior, such as ability to prioritize, critically think, use clinical judgment, communicate, it's done subjectively by the evaluator. So think back on your clinical evaluation tools and, are they rubrics? Do they have descriptors? Are they empty boxes that have some examples of what belongs in them? And does everybody agree that they're interpreted the same way? So that's my question to you now. Do all your clinical instructors interpret your evaluation forms the same way? And if so, how do you know this? If you could put it in the chat box, that'd be great. Excuse me. Amy says it's hard to know. Do any of you actually do an inter-rater reliability procedure with your evaluation tools? No, I haven't either. I've never worked anywhere that has actually done inter-rater reliability for clinical evaluation or for simulation or for skills. But honestly, everywhere I've worked should have done it, especially if any kind of high stakes outcomes are on the table. The IRR needs to be done. And failing clinical and repeating a course is high stakes for these students and the profession. So when I talk about inter-rater reliability, it's not just we do it once and we're done. So here's an example in skills labs. So inter-rater reliability, it should be done with everybody who's assessing a student's performance. So you get together, you review the checklist, you answer questions that each other has, you show a video of somebody completing a skill, preferably where they don't do everything correctly, and then have each person individually rate the learner, and then compare the findings. And then when there's discrepancies, you talk through those, and you make a decision on how the group, not how that person, how the group is going to handle that type of situation when it happens. Then you do another video. And you keep doing this until everybody reaches a predetermined level of agreement. Now, here's the challenge. You might need to do this again at noon. Or you might need to do it again at the start of day 2. Because here's the reality. I mean, I know that when I was evaluating skills in the lab, by the end of the day, I didn't really care anymore. And, you know, you hate to admit that, but I started to like miss where they put the Q-tip and watch exactly how they remove their gloves, because you get tired, you get fatigued doing this. And so this inter-rater reliability is really important. Now the question is, you know, if we can't even grade skills the same way when the student's right in front of us with all of our undivided attention, then how do we possibly give fair clinical evaluations to these 8 eager novice students that are running around trying to figure out how to take care of people that are acutely ill? First, we have to know what exactly it is we're trying to evaluate in clinical. So that's my next question to you is, when you take your students to clinical, what is it you're trying to evaluate? Amanda, I'm just seeing what you wrote before. It looks like you've got a pretty decent process in place. Evaluating your rubric, tracking the unsatisfactories so that you can see the themes. That's good. That's a great start. So pretend you're in the hospital now. Simulation's a little easier to figure out what you're going to evaluate. But when you've got these 8 students in the hospital, what do you want to evaluate at the end of the day? Okay, communication, collaboration, prioritization, clinical judgment. Amy, do you have columns on your evaluation form for each of those? Because that sounds like our evaluation form that we had too. They're integrated. Okay, good. Okay, so when we look at replacing one clinical method with another, like I mentioned at the beginning, with maybe simulation replacing traditional, all of our ways of teaching are compared to the traditional clinical model. So what is it that happens at traditional clinical that makes this the gold standard? So some colleagues and I did a systematic review, and we wanted to find out what learning outcomes are reached using traditional clinical learning environments. So hospital clinics, skilled nursing facilities, in that type of situation. And we only looked at undergrad pre-licensure programs. And we used every name for clinical that we could find in our literature as our search terms. And there were 43 of them. So we call clinical a lot of different things. And honestly, we assumed that we would find a lot of clinically related outcomes, since this has been the gold standard since, I don't know, Florence Nightingale, right? Well, here's what we found. Nothing. Not one single study met the inclusion criteria. And we had what is called an empty review. These are really uncommon and not extremely easy to get published either. And they usually mean that the search terms were too narrow, which we don't believe was the case because we had 43 of them. But, you know, we have to say, just because we didn't find it doesn't mean that we don't have research on clinical outcomes. It just means it wasn't published or not in a way that it could be found. But at the end of this review, we had nothing to show in the quantitative literature outcomes for our gold standard of training. So then we thought, well, maybe it's in the qualitative literature. So we did the exact same systematic review with the exact search terms and everything. And we found 6 papers that met the inclusion criteria, but they were really different. And the focus really wasn't on student clinical learning outcomes. There was one paper about international or foreign clinical placements. There was one about a nurse-run clinic, night shift clinical, transition to professional identity, practicing as a clinical dyad with the instructor and the student, and development of caring skills. But because there were really specific types of clinical, and they're not really reproducible to large populations, not everybody can send their students to another country, we felt like they weren't really looking at outcomes in the right way, and we didn't have anything that we could use as recommendations or to build on. So then during the early days of the pandemic, we became really concerned about the outcomes of nursing education because of how instructors had to move everything online. And, you know, it's a kind of feeling like a distant memory now, but everything happened so fast, and you guys had to put courses online, simulation had to go online. Nobody could go to clinical anymore. And you had to like figure this out either over the weekend or during your spring break. And a lot of people had to teach online, and they never had taught online before. And it's a skill set unto its own. Same with people not doing simulation work online. And plus, everybody's anxiety levels were so high because we had no idea what was happening around us in those early days. So a group of us revised the Clinical Learning Environment Comparison Survey, which was my dissertation tool. And we changed it to version 2.0 and it allowed comparison of 3 learning environments and how well the students' learning needs were met in those environments. And in short, what we found was that screen-based simulation was lowest in every single item. That wasn't surprising at all because it was all new. Honestly, we had intended to redo the study a year later, but we ended up having to do snowball sampling. And so we couldn't go back and ask the same people and do a good comparison. So we let that go. But also the scores were highest for traditional clinical environments again. So it's just telling us again, there has to be something there that is making a difference, even though we didn't find it in the research. So what is that something? I'll get my mouse to move there. So we think from reviewing all of our research that the answer probably lies in the professional socialization that comes with being in that traditional environment, working with other nurses. So while we don't know what learning outcomes occur from traditional clinical, we do know that professional and ethical comportment can be developed in the clinical environment. And that's really the dimension of nursing practice that fosters that cooperation, collaboration, effective communication, team cohesion, learning how to work as a healthcare team with your nurses and other healthcare professions. And these things are difficult to develop in a lab or in a virtual environment because you don't have that direct interaction with the profession that you're becoming part of. So there's a need to be around other nurses in order to learn how this profession works. And I think we need intentional research to discover what's best learned specifically in that environment. Now, one of the challenges is, as nurse educators, that we have this seemingly arbitrary and wide range of number of hours that our different degree programs have to adhere to. And we're all tasked with producing generalist nurses. They all take the same licensure exam, but we certainly have a wide variety of ways to get our students there. So the range in clinical hours is really an interesting challenge. So hopefully this discussion has stirred up some questions for you and maybe even helped you start to think differently about some of the challenges related to evaluation of students in clinical environments, and all of them. Now, I understand you're interested in measuring nurse competence in simulation, as well as other clinical environments. So, where to start with that? And I've been talking with my friend Susie a lot this week about this topic, and I think we've become pretty convinced that you can only probably, maybe, see clinical judgment or critical thinking in the traditional clinical environment when something doesn't go according to plan. So consider that traditional clinical day, either in the hospital or in simulation. Students plan it all out with care plans, maybe concept maps, lists of things they need to do. You also have your plan as the clinical instructor. Now, a typical day on a clinical unit, the student has one patient, and that patient is usually easy enough for a student nurse. And the day is usually going to be pretty routine for that student. So as long as everything goes to plan, they don't really have much of a need to implement clinical judgment or critical thinking. It's only if something changes. But what if you're not there to see it and to see how they react? And I think that sends us back to the beauty of simulation, because we can create the change and we can observe it. So I'm just going to share some considerations and suggestions for you as you move forward. I know you're interested in evaluating competency, but I think you have to really decide exactly what you want to measure. So competence in what? Is it competence in communication? Is it competence in managing a patient for 8 hours? Is it competence in communicating with the family? I mean, you might require a variety of different evaluation tools in order to really decide if that student is competent. And then think about your evaluation forms and the words that are in the boxes. If you have examples in your boxes of how the learner is perhaps demonstrating that particular competency, you have to think about, how do I really see that in a person? How do I operationalize those words to know if the student is meeting that competency? And then, do the other instructors agree with you? And that goes back to the inter-rater reliability. Then I think it's important for us really to start thinking about what learning environment is best used to measure the different competencies. So I think it's really obvious that psychomotor skill competencies are probably best evaluated in a skills lab. Now, they get that repetition in practice. They should know how to do the skill before they get out there with the real person. But as I said before, we spend a massive amount of time on our clinical day making sure they do the skills right. We've already done that. So is that a task we can share with the staff nurses and not have to do that ourselves? Then in SimLab, I think the key outcomes that we can look at there for competence, pattern recognition. We can have 4 different scenarios with 4 different respiratory problems. They should start to recognize patterns of desaturation with that patient. They should start to recognize patterns of how the sounds they're hearing in the lungs correlate to different diseases. We should be able to evaluate their problem solving, their prioritization. And again, this is where we can really hone in on that critical thinking and clinical judgment, because we create the change in the patient's condition. We know when it's going to happen, how it's going to happen. All we have to do is observe their response to it. And then again, in the traditional clinical environment, maybe that's where we look at their skills and competencies with cooperation and collaboration. How do they communicate with the nurses? How do they communicate and collaborate and be a part of this healthcare team? And how do they manage their patients' care as an advocate within that team. So some suggestions. I'm going to suggest that you don't evaluate your students every single clinical day if that is what you're doing. At least not formally, because they're there to learn. You know, let them get used to the environment, your expectations, the nurse's expectations, the doctor's expectations. They need time to decrease their anxiety long before you start giving them unsatisfactory evaluations because they messed up on day one. Of course, they're going to mess up on day one. They're a nervous wreck on day one, and they don't even know where the bathroom is or how to get to lunch. And we're hovering with these evaluations. So what if they had an 8-week clinical and we evaluated them at week 4 and we evaluated them at the end? There's research out there that shows that evaluating clinical experience randomly over time gives you the same information at the end of the experience. Then, you know, FERPA became a problem and, you know, sharing information about students. But what if at the end of each clinical, the instructor and the student co-created a one-page plan that noted their strengths, their weaknesses, and concrete ways that the next instructor could help them to improve. If you co-create this with the student, then it's shareable with the next person. I mean, as long as the student knows that that's the purpose of it, but you know what I mean. Now, here's something to think about. Right now, we tend to evaluate skills, and the students can fail based on the skills. We tend to not evaluate simulation, and the majority of the schools have a philosophy that it's for learning and not for evaluation. And then we go to clinical, and we're back into evaluation and failure mode again. So we're really inconsistent across our clinical environments. What if there was one clinical grade that encompassed all of the clinical environments at the middle and the end of the semester? How would that look? Another suggestion is, you know, pay attention to the AACN essentials, the new competencies, but they're not, you have to create an objective way to measure these because they're not measurable as written. So there's been a lot of discussion about, well, this looks great, but how do we measure this competency? So that's a big faculty challenge as well. Now, the National Council of State Boards of Nursing has their new clinical judgment, it's a tongue twister, clinical judgment measurement model. And I actually like this quite a bit. They're using it for the next gen NCLEX questions. And they're set up like, you guys are probably all familiar with them, but in case not, they're set up as an unfolding case study. So again, pretty similar to what we're trying to do in simulation. And the questions are designed so that you understand if the test taker is recognizing the clues, if they're analyzing the cues, if they're able to prioritize hypotheses, generate solutions, take action, and then evaluate the outcomes. And so it's based on the foundation of the nursing process, but it also has so many similarities to the Lassiter clinical judgment rubric. And then last, I don't know if you use concept maps when you do your clinical. This is something that we did years ago at a school that I worked at, and I didn't see the value at the time. A few things I didn't see the value at a time, but we had the students make these concept maps before they came to clinical based on the information. You know, they would go do a chart review, meet their patient the day before or the morning of. Then they would make these concept maps and create all these different links between pathophysiology and medications and assessment and things like that. And honestly, some of them took hours. And I know now that they probably spent more time trying to get the right colors and the arrows going in the right direction, you know, and making faculty happy than they were actually learning from it. And I rarely had time during clinical to look at these. And so I would take them home and I would try to figure out what all of these different connections meant. And it's not possible. There's no point in taking them home because the only way to understand these is to have the student explain it to you. So if you do that, that's where you're going to learn about their higher order thinking skills, because it's just like debriefing. You might say, you know, I see you have a dotted line between X and Y. Tell me about that connection between heart failure and the diuretic. How does that work? And then you hear from their brain how their thinking is. And a lot of times, the thinking is correct, the answer is wrong, and vice versa. But if you listen to how they're processing, you can find those errors and you can help correct them that way. I don't think concept maps should be graded at all, because it's the student's mental attempt to understand a patient they haven't even taken care of yet. How can you grade that? So my suggestion is that you have them do it afterwards and walk you through their care map. And then you're going to know if they truly understood what they did that day, not what they thought they were going to do that day. So that's really all I have for you. I hope, again, I've given you some things to think about, and happy to answer any questions that you have.
Want to invite people who would like to ask him questions verbally to go ahead and unmute and ask at this point. And Kim, I know I asked you to add the 2 slides, but I'll let you stop sharing unless you want to go ahead and show your references slide, and then I can show the last 2.
Okay, let me skip ahead here. Okay, here's the references. And of course, you guys, you'll give them a copy of this, is that right?
We can put it out to the group. Yep.
Okay, you're welcome to share the slides. I have no problem with that.
Thank you.
So yeah, there's the websites for the AACN Essentials, and then each of the 4 papers that I mentioned, and then the NCSBN website is the last one. And then, yeah, now it won't let me go backwards to your slides. So I will stop sharing. Okay, there you go.
It looks like there's a good question in the chat around whether you have any of these tools, the rating tools and tools to develop rubrics that could be shareable.
I'm not sure which rating tools. Are you talking about the simulation effectiveness tool modified and the clinical learning environment comparison survey? Those tools? Oh, and the Lassiter, yeah. So I'm going to put a website in here. I have a website. It's called Evaluating Healthcare Simulation. Evaluating Healthcare Simulation. And it has all of my tools as well as some that other people have done. I post them on my website as long as they've undergone reliability and validity assessment. And then they're freely available. You can go click on it and download them right away. I used to have you had to fill out like a form because I was trying to keep track of how many downloads and stuff like that. But we reached, over 8,000 downloads from 89 countries. So I decided to just stop tracking it at that point because it did what I hoped it had done. The Lassiter one, I believe, is in her journal article. Mine are not in my journal articles because I wanted to put them on the website and I didn't want to have to get permission from publishers to manage my own creation. Which one couldn't you find from the Google search, Lindy? The Lassiter?
Lassiter, yes, ma'am.
Okay.
Lindy, I have that article. I can send it to
You
you.
have it? Okay.
That would be awesome. Thank you.
Yeah, you know, it is a challenge with the tools because like the SET-M, I don't know if any of you are familiar with that one, but that one, it seems to cross all healthcare professions that are like apprenticeship based education. And so I know it's been used with respiratory therapy and physical therapy and occupational therapy. And I've used it 3 times myself with med students. I just have not published, and I need to, the reliability and validity with them. The problem is that, you know, when they get used routinely in a school, they're not going to publish that, right? It's usually only if you end up doing research that you get that push to publish. But nobody has come back to me to say that it has not worked for their discipline. And so I think that one's a good one to go across. People are using it for IPE as well. Now, the Clinical Learning Environment Comparison Survey is absolutely 100% designed for nursing. I have had a couple other professions use that too, but they decide, you know, they go through and look at the validity against their curriculum, and sometimes they might just omit a question or two and then it works for them. So that's fine.
I have a question for you, Kim.
Sure.
So are any of your simulation teams looking or active in simulation research? Like, do you have some projects going on now looking at these skills in the simulation labs?
Do I personally? I do not.
Okay.
I do not. And it's basically a function of where I'm working right now. That well, Dawn can tell you all offline, but we have a little staffing problem. And so we're mostly in survival mode every day. And while we teach the best practices and we're trying to get everybody trained to best practices, we're not at a point yet where we're able to do the research. Unfortunately, because I have got such a diverse population that it's really a great opportunity. It will come. Yeah.
Thank you.
Mm-hmm.
Anybody have any other questions? I'm going to pull up my last 2 slides while you guys put your thing.
Kind of decided over the last couple of years that, you know, I'm at the point in my career where it's kind of fun to just think about the illogic of a lot of the things that we do and just wonder why. You know, why do we let them tell us that once a day meds have to be given between 9 and 10? Why do we allow that? We're professional nurses. And so, yeah, I like to just like stir things up a little bit, but hopefully it'll get you thinking. And whoever gets that changed, you just email me and let me know. I'll be so proud of you.
Okay, I got it. Okay, so if there's no other questions, in respect to everybody's time, I want to thank you, Dr. Layton, for a wonderful presentation, and to all of you for attending today. We really appreciate your engagement in our session on evaluating clinical education. Our next brown bag will be in May 2023, but the topic and presenter are TBD at the moment. If you're interested in learning more about a SIM-focused topic that we have not covered so far, let us know what you would like us to present, or if you can think of something you would like to present, we would be open to that as well. We have recently provided presentations on moulage, safety and simulation, SP training, current research priorities in simulation, and now evaluating clinical education. You're welcome to reach out to me via email or by phone and drop a line. As always, if you have questions about anything in the presentation, feel free to reach out to any one of us. Our website, carolinasimulationcenter.org, contains our contact information. And I'm sure Dr. Layton, well, I haven't asked her yet, but I'm sure she wouldn't mind you emailing her as well with a question about the presentation.
No, of course not. Anytime. Anytime.
And Groucho and Mrs. Muriel have returned from our very first brown bag event, and they also want to thank you for attending and to point your attention to a link that I posted in the chat for the post-event survey. You know, simulation, you always have to fill out a survey. But there is a QR code on the screen as well, and both the QR code and the link will take you to that post-event survey. We'd love to hear your thoughts and reflections on our brown bag series. And is there anything else anybody would like to share before we close? Speak now or
Okay.
forever hold your peace.
I have something funny to share if you go back to the last slide with the brown bag. So 2 nights ago, sound asleep, and I hear ding dong, ding dong. And I'm like stumbling to the door. I don't have my glasses on. It's, you know, it's 12:30 in the morning. And it's a man delivering my cat. I'm like, but I don't have a cat. He's like, this is flat 302. This is your cat. And I'm like, I don't have a cat. So he's like, well, what floor am I supposed to be on? And he's holding out his delivery paper. I'm like, I don't have my glasses on. I can't see a thing. Oh, it's right here. I'm like, it doesn't help. I can't see a thing. Okay, but this is your cat. I'm like, no, this is not my cat. So when I saw this picture today, I just burst out laughing. Because I'm like, there's the cat again. I don't know.
Thank you, Leslie.
Never a dull moment in Doha.
Right.
Oh,
So, okay, one thing I would like to ask you, how do you actually say Qatar?
yeah. You can say Qatar, 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 and all of them are perfectly fine. Yeah.
Right.
There's over 110 languages spoken here. But English is everybody knows English, but it's with so many different accents and dialects and stuff that I'm sure the people who are from here gave up long ago. So any of the above are acceptable.
Well, if there's nothing else, thank you so much for joining us today and have a great rest of your day.